a consultant and clinical educator. Tiffany walks in it with passion and purpose. She could not picture herself doing anything else. A little bit history of Tiffany. Assisted living director was her very first job as a nurse. It prepared her with caring geriatric population. Thank you. Whether that was dealing with cognitive changes, health, decline, falls, or safety, it also helped help her for the emotional side of death and dying. Her experience includes specialty training at UT Southwestern Hospital in neuro and rehabilitation. She later found her niche in hospice and have been working in the specialty for 15 years. She grew and thrived in this space. So let's welcome Miss Teffany Odie.
Thank you. And as she says, been in hospice about 15 years. Going on about 16 years now. I remember walking into a room. We got a late call. It's probably about 8 o'clock in the evening. Rush job. Patient's going to be discharging from the hospital, going home. By the time that I arrived at the home, there were 3 siblings, several family members. The paramedics had unhooked her, put her in the bed, so she was waiting. But prior to going in, I sat with the family, with our chaplain. Kind of went over hospice, what it isn't, those type of things, because we give informed consent prior to just saying, hey, sign on this dotted line. So I sat with the family, we went over everything. We had one sibling who was like, no way, they're going to give her morphine, and she's just going to sleep all day, and it's going to kill her. And then, so had another sibling is like, no, my friend had hospice, her mom had hospice, and that's not how it went. The other one was stuck in the middle. If I go with this sibling, they're going to be mad at me. If I go with this sibling, they're going to be mad at me. So, but this was the person that was the POA that would make the decisions. So, after we explained everything, I said, well, okay, I'll tell you what, I'll let the chaplain finish talking to you guys. I'm going to go in and I'm going to do the assessment. I want to meet your mom, kind of get a feel for what is it. I can tell you guys a little bit more, explain what a care plan is and so forth. So I went in, nice African-American lady. She was around 75 years old. She was lying in the bed, multiple disease processes going on, primarily hypertension, cardiac, which affected the renal. She was a diabetic. Doctor said she had these ongoing problems for years. Eating habits were all over the place as well, which worsened the condition. Okay. She did have an attending physician. Matter of fact, she had a physician that came to the house, a visiting physician monthly, right? So I went in and I started assessing her and got down to the feet area. And on her feet, her toes were black. They were solid black. They were necrotic at this point. And one was in a bandage. And they were like, oh yeah, the bandage looking. They're like, oh yeah, and those feet are really bad. And I'm like, yeah. They were like, and one was dangling. One toe was dangling. And they said, well, what do we do about this? So I assessed. And I said, it's to the point to where there's not much that you can do about it. And so what caused this was the heart condition and the diabetes and all these comorbidities that tie in together. I said, well, have they not addressed these things with you? And they were like, no, she's been bad for a while, and someone said she needed to be in a nursing home. We're not letting her go to the nursing home. I said, okay. I said, well, here's what most likely is going to happen. And I explained to them that the toe eventually may fall off. I always use the word may because just because what it looks like doesn't always mean that's what it is or going to be. But if I tell you and explain to you as a nurse, you're a little bit more prepared, right? So we go back in and once I give my, assessment and let them know what we can do, they just put her on hospice. The next day, I do a follow-up visit, and sure enough, the toe fell off overnight, and that was kind of traumatizing to the younger sibling. Um, and of course, grandkids and things like this, and they hated to see, the patient like that because she wasn't cognitive. She was on her very last stages. Matter of fact, she died. She wasn't on service for 3 days, and she passed away. So, what I will be talking about today, because if they had just got hospice in there a little sooner, there's a lot of things that we could have prevented, we could have educated, we could have treated. But when you ask family members why they didn't, elect hospice, or did they not explain to you about hospice, they were like, no, not until the last minute. The doctor wanted to treat, 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 treat. And then when the doctor finally sees that, hey, there's nothing else I can do, I've tried every experiment on them, uh, then they decide to refer late. At that point, the only thing we can come in and really do is try to keep them comfortable. So that's where you get that from, is that they only give morphine and the patient passes away. Okay, so that's where that originated from. So the goal now is, or the big push is to educate on what palliative care is and what hospice is, and what's the difference. Just so that the benefit can be taken sooner rather than later for optimal outcomes. So, the topic of today that we're going to be discussing is dispelling the myth surrounding hospice. What is hospice? What hospice isn't? So, and afterwards, we will have an opportunity. I'll give you guys an opportunity to answer questions. Um, but a lot of times throughout presentation, um, because if you're anything like me, my train of thought sometimes goes from here to there. So I don't mind to that in between or right after talking. If you have questions, I don't mind you raise the hand and ask that question. That way, it's not 35 minutes later and you forgot, or you got multiple questions at that time. So I don't mind a little question Q&A throughout as well.